To David Cote from Alberta in Canada, and he's going to tell us about biodegradable corticosteroid impregnated dressings, cheap and effective. Sounds great.
Cheap and effective. Thank you very much for having me here today. It's such a pleasure to be able to present again in person. It's been almost 2 years. In Canada, we weren't allowed out of the country for about 20 months, so this is my first trip across the pond. Thank you again. All right. So I think, thank you. I think the reason why I have some reason to stand on this stage to talk about this topic was because of a paper that I authored when I was a chief resident almost 11 years ago with Aaron Wright, where we looked at triamcinolone impregnated nasal dressing following endoscopic sinus surgery. And this was the very first placebo-controlled blinded study looking at corticosteroid impregnated biodegradable dressing following endoscopic sinus surgery. So just as a background, of course, everyone knows that rhinosinusitis is a huge problem. It affects up to 15% of the adult population in North America. Annual costs exceeding $12 billion annually, and endoscopic sinus surgery has been proven to be an effective and safe option for restoring patency to ostia and function. There's growing focus on increasing the longevity of these desirable outcomes, which of course is the topic of this session today, following endoscopic sinus surgery, specifically aiming at reducing that postoperative inflammation, polyp recurrence, and adhesions. Recurrence rates, unfortunately, despite very good surgery, can be as high as 70% at 18 months. And polyp recurrence is, of course, associated with increasing rates of revision endoscopic sinus surgery. Now, we know from the published literature that topical corticosteroids in the form of nasal steroid sprays have been proven to improve those three markers of poor outcomes. And devices to medialize the middle turbinate have also been studied extensively. So we were looking at ways to investigate approaches that will harness the benefits of the steroid as well as that middle turbinate medialization. And different approaches have been taken historically, either non-absorbable nasal packing, absorbable nasal packing, and ultimately absorbable nasal packing with subsequent addition of steroids, which is what I'm going to be talking about today. So a lot of the legwork for this talk, I have to give credit to Zheng et al., who just published a wonderful review article on this, where they did a systematic review looking at the literature over the last 11 years since our study came out to people looking at absorbable steroid-impregnated nasal packing following endoscopic sinus surgery. And what they found with their PRISMA algorithm was ultimately 8 studies over the last 11 years. So the first was the one that we published, and that looked at nasopore. Then there was a study that came out of China where they looked at different doses of mometasone, and I'll go through each of these studies as the talk continues. A group out of South Korea, and then a group out of Poland, all using nasopore as the packing, but different steroid regimens and different outcome measures. Other biodegradable dressings that have been examined include calcium alginate, which is, of course, widely used in wound care, and so a group out of South Korea were using calcium alginate intranasally with steroid impregnation. And then a variety of gels. Luke Rudmick, who's a colleague of mine who's in Calgary, same province, different city, they looked at using Sinofoam, but their study was the one study out of this group of 8 that did not look at patients with polyps. So this is chronic rhinosinus patients who are non-polypoid. Then there is a group out of Iran using gel foam, and finally a group out of Australia using chitosan dextran gel. So which steroid to use is the big question. So we used triamcinolone because at that time there was really good evidence to support triamcinolone as a topical intranasally for 7 days. The group out of China decided to use mometasone, and they had a multi-arm study where they looked at 4 cc's and 8 cc's of the mometasone and leaving the packing in for either 1 or 2 weeks. The group out of Korea used triamcinolone but at a lower dose and left it in for longer. And finally, the group out of Poland used a betamethasone and left it in for a week. The group examining calcium alginate as the packing used the same triamcinolone regimen that we had used. And then for the gels, the group out of Calgary used dexamethasone mixed in with the Sinufoam. The group out of Iran used triamcinolone, but again at a lower concentration. And finally, out of Australia, they were using budesonide. These studies also varied in terms of their postoperative regimens. So in terms of how much steroid they were having perioperatively, postoperatively, the use of antibiotics and whether that would be playing an effect. In our study, the patients received cefprozil for 7 days postoperatively, saline starting at postoperative day 1, and the intranasal corticosteroids resumed at postoperative day 7, and usually as budesonide saline irrigations. The group out of China used an unspecified antibiotic that was not described in their paper, and then they used intranasal mometasone after packing removal. Zhu et al. Used cephalosporin for 2 weeks, and then intranasal corticosteroids starting after 14 days. And the group out of Poland used Cipro for 2 weeks, and then again, intranasal corticosteroids starting after 14 days. The group examining the calcium alginate, they used levofloxacin for 3 weeks postoperatively, and a pretty significant systemic steroid regimen as well, with 16 milligrams for 2 weeks, and then a taper for 1 week at 8 milligrams. With saline irrigation starting after postoperative day 7 for packing removal. Amongst the gel group of studies, the perioperative prednisone continued as a postoperative taper for 10 days out of the group from Calgary, with amoxiclav for 1 week preoperatively as well as 1 week postoperatively. The postoperative regime for the study that came out of Iran, unfortunately, was not described in their study, and the group out of Korea did not, the group out of Australia had an unspecified antibiotic that was administered on postoperative day 1 only. Outcomes measures also varied significantly between the different studies. We used the Lund-Kennedy and the post scores at postoperative day 7, 14, 28, 3 months, and 6 months. And we found significant difference in both the POSE and the Lund-Kennedy scores at the 7 and 14 days, which was lost at postoperative day 28, but then resumed to be significant at 3 and 6 months postoperatively. The group out of China that had the multi-arm study, they found no difference in the group that had the low-dose mometasone for only 1 week. The low-dose mometasone for 2 weeks did have significance at postoperative days 14 and 28 only. At the higher dose mometasone for 1 week had difference at 1 week, 1 month, and 2 months, and the group that had the highest dose for the longest length of time had the most significant difference for the longest length of time, up to 3 months, which was the end of their data collection. The Zhu et al. Have also looked at POSE and Lund-Kennedy and found significance at 1 month and 2 months. They're, of course, the ones that had the triamcinolone but at the lower dose. So they did not see it significant beyond that 2-month period. And Grzechowiak et al. Saw Lund-Kennedy significant at 3 months. They also used a visual analog scale as an evaluator, and that was significantly improved at postoperative day 7, 14, at 3 and 6 months. as well as on postoperative endoscopy, crusting was significantly improved at 10 days in treatment compared to control, and secretion and edema were significantly different at 3 months. The study examining calcium alginate as a packing showed significant post-reduction at 8 weeks. For the gels, the group out of Calgary saw no significant improvement seen in their patients in their non-polyposis patients at any data collection interval. The group out of Iran saw a significant difference in the BTT test at 8 weeks, suggesting that impregnated steroid, specifically at the olfactory groove, could improve olfactory outcomes. And then the group out of Australia, Ha et al., saw significant improvement in ostia size at 2 weeks and 12 months. And we talked about cheap and effective, so we've shown that it's effective. Is it cheap? Well, yeah, I think that steroids, all of the ones that we've described in these studies, are less than $10 per application. The nasal packings, however, can be variable. The costs can vary. I think the nasopore is quoted in American hospitals at $130 US for an 8-centimeter piece, which of course can be used between the two nasal cavities. Our price in Canada is a little bit cheaper than that, but you know, it's not an insignificant cost, but in the context of endoscopic sinus surgery, it's really not significant. And then calcium alginate's really inexpensive. It's about $10. So in summary, the literature shows 8 prospective RCTs have been done with placebo-controlled looking at corticosteroid impregnable biodegradable dressing following endoscopic sinus surgery. The overall, it's consistent with benefits to postoperative outcomes in chronic rhinosinusitis patients with nasal polyposis in both early and late evaluation. I'll echo some of the other speakers in saying that we need further research to determine the ideal packing and steroid dose and reduction in need for revision surgery, which was not an outcome that was ever examined specifically, is how does this impact the likelihood of requiring revision surgery down the road. And there's not been any evaluation now that we have different subtypes of CRS. Do the eosinophilic versus the non-eosinophilics have different outcomes in regards to the utility of these steroid-impregnated dressings? And finally, particularly as biologics are starting to become more and more normative, how does this play in a role? And I don't want to take the thunder away from the next talk, which I'm really excited about, but that certainly could be another question to be asked. Anyway, thank you very much.
So, David, just a quick question here. How does patients with recalcitrant CRS, fit into this? How would you pack them differently than a juvenile case with, the first surgery?
No, actually, it's become the standard of care for both primary and revision cases for us at our center to be using this specific dressing. So it's standard throughout.
Okay. Any more questions from the audience? Go ahead.
Thank you for a good talk there, but I have a comment as well as you can take it as a question. All the dressings you talked about, they last only 1 to 2 weeks. So how do you feel that they go about changing the whole course of it? And the maximum one study had said was 6 months, another was 12 months. How do you say that the effect was so long and so prolonged?
Okay, so your question is, because it lasts for such a short period of time, why are we seeing those results so significantly? Yeah, I'll be honest that when we were doing this study, I was not expecting a significant difference at 6 months that we did end up seeing. So I think that there's something that happens in terms of modification of inflammatory factors that happens in that immediate postoperative period that somehow seems to change synechiae and edema even in the long term.
Go ahead.
Hi, excellent talk. Sorry, I may have misunderstood, but you are using biodegradable absorbable packs. And most of the studies, they were removing the pack after 7 days. So what are you removing? Because in my experience, it's just looks like snot. And why do you feel like if you put an absorbable pack, why do you feel you need to remove it?
That's a good question. So that's just become the standard. So while it's resorbable, it doesn't completely disappear. So it does sort of linger around as sort of a sludge. And it's been pretty standard, regardless of whether it's there or not, that we do debridements afterwards. There are, of course, some people who do throw in nasopore and don't debride at the postoperative periods, usually at 1 to 2 weeks postoperatively. But that's not an arm that we specifically have looked at.
Okay, thank you, David.
Thank you.
And now I